cortisol is released in a pulsatile fashion. This is actually not the release, this is the cortisol level. So if you actually look at the cortisol pulses, they will be even more sharp. But because of the CBG effect, you have got more flattening in terms of response. So what does this show, Dhwani? What are you seeing here in this curve? So cortisol is basically a daytime hormone. So you want it predominantly to be working in daytime. You don't want it to be there when you are sleeping, because then your stress will unnecessarily go up. So it's clearly you have got a rise in the morning, and that's why if you want to assess deficiency, this is the best time to assess. And it's going down lowest around midnight 12 when you want to assess for cortisol excess. That is why midnight cortisol is assessed from that regards. Now, what's important to remember in this regards that there are multiple factors which will control. The CRF activity will control, the stress level will control, and then there are effects of the day-night cycle and the light-dark cycle. Which is more important, day-night cycle or the light-dark cycle? So basically, if you look at it, what does it mean? Suppose you are kept in an environment where day becomes dark and in night you have light. So this is mainly done in terms of rat experiments. So what they will do, they will change that. And what they find that the daylight cycle is more, like the light dark is more important than the day night. This is important to remember. Very importantly, this rhythm is not established in infants. So we always say, okay, check the cortisol level at 8 a.m. But in infant, this is not established. So in the first year, you can do cortisol in a random sample. You don't need to wait till next morning to assess those levels. And importantly, cortisol has to be assessed in the light of your sodium level, in your blood pressure, in your glucose levels as well from that regards. Very significantly, if somebody has had a intercontinental travel, so if there is a lot of time difference which is happening, it may take few days. So if somebody has come immediately from US, don't check the cortisol immediately because your rhythm will be disrupted. Now, of course, we know that cortisol level will increase with stress, with fever, with hemorrhage. So you have to be cautious in assessing in those regards and hypoglycemia, and they will decrease in hyperglycemia. So in diabetes, you can have a slightly lower level if your sugar levels are very high. If somebody is given exogenous steroids, of course, they will come down. And cyproheptadine is also an inhibitory factor. And some patients are getting cyproheptadine because of an appetite stimulant. Then your cortisol levels will be low, that you will identify. So now we have a 14-month-old girl with failure to thrive. Weight is on the lower side. Height is normal. Sodium potassium is normal. Thyroid is normal. Cortisol at 8 a.m. is low. So what will you do from here? So very importantly, any single low cortisol is not important unless you have hyponatremia, shocks, illness, or other scenario. The second thing is that here your diurnal rhythm is not established. So the higher level in the morning you can't take as a cutoff. So this is a scenario you cannot rely on this. So you have to do a further workup from there. Now, from here, the cortisol, as I discussed, is basically a steroid. You would need to carry this steroid through the blood. So you've got a cortisol binding globulin, which is a major binder. Along with that, you've got alpha-1 glycoprotein and albumin. Now, CBG is a major binder, which is 90% of the binding capacity. Levels are increased via the use of the estrogen. So if there is any increased level of estrogen, like pregnancy or oral contraceptives, levels will go up. So if you have a patient who is being started on OCs, you expect that their requirement will go up. Or they will become like having lethargy, weakness, their requirement is going up and you're not compensating. Similarly, the levels will go down with liver disease and nephrotic syndrome. And you have albumin, which has got a reasonably stable level. Now, one thing to remember is that CBG is also important to really bind and keep the hormone inside. So if you give somebody a high dose of hydrocortisone, beyond a cortisol level of approximately 700 or 800 nanomole per liter, the binding capacity of CBG will be overwhelmed. So what will happen? Whatever cortisol will go into the urine. So that is why giving repeated injections of hydrocortisone, you will not get good levels. Better to give an infusion. So at a given time, the levels don't go that high. Just like if you give injectable vitamin D, levels will go up. They will go in the urine. Your levels will not rise. While if you give an oral, you will have a better outcome. So this is something to remember. And that's why we prefer infusions rather than the boluses. Now, synthetic steroids like dexamethasone and prednisolone do not bind very well with CBG. So their potency becomes more and their effects will also become more. There are other factors, but this will definitely be a factor which causes higher potency for these agents. Now, as I said, CBG has a saturable kinetics, and because of a saturated kinetics, if your level go above 800, they will basically be lost in the urine. So no point giving very high doses. After a level, it is not going to work, and better to give other infusion so that you have got a more stable control from that regards. So 16-year-old girl with obesity and hirsutism, Manoj, menstrual irregularity, buffalo hump, all features of looks like Cushing syndrome. Now, in that scenario, what was found was that overnight suppression showed a non-suppressed cortisol level. ACTH level was detectable. So it was diagnosed as an ACTH-dependent Cushing syndrome, and MRI was advised. What would you like to look at before you go ahead with the MRI?
So buffalo hump is not a characteristic features of the Cushing syndrome. So might we see, as we discussed, he was on some treatment like estrogen progesterone, which has increased. So we have to first confirm by you.
So very importantly, before you go ahead with assessment of adrenal axis, look at the drugs. If somebody is on estrogen progesterone, there is no role of a total cortisol based assays like morning cortisol or in the form of a midnight cortisol or a overnight dexamethasone suppression. You go for free cortisol based assay, either the urine or the saliva. These will be the ones which you will go into that. That becomes important. So she was on estrogen progesterone preparation and UFC was normal. Dhwani, 12-year-old boy with liver disease, sodium is low, urinary sodium is low. So it looks more like a fluid related, like a hypovolemia rather than anything else. He actually had a fluid overload. Now cortisol is low and he was advised steroids. Do you agree?
In the presence of liver disease, we will also have low.
So you will have a falsely low, ACBG will be low. So you will have a falsely low level of cortisol in this scenario, which is not a reliable marker in that regards. Go for a free level in that perspective, and this becomes important. Now, before we close today, we'll just go through about the local metabolism, which I was talking earlier. So cortisol and cortisone are two structures which are quite similar, and they keep on converting via the enzymes 11-beta-HSD1, which is a bidirectional enzyme, largely converting cortisone into cortisol. But if your cortisol becomes high, it will also act as a safety valve, converting it back to cortisone. So this is mainly at the tissues in which the glucocorticoid is acting, while 11-beta-HSD2 is predominantly an inactivator. It is there mainly in the mineralocorticoid responsive tissues like kidney, colon, and sweat gland, and it is converting cortisol to cortisone, and deficiency of this causes apparent mineralocorticoid excess. You can all go and have a look at our website, our courses which are available, and the mobile application. So